Assalamu alaikum, good morning. Actually, because of the limited time, I am going to concentrate on congenital causes of chronic diarrhea and malabsorption, because we are starting to encounter an increasing number of these cases in our community, possibly because of the increased consanguineous marriage. As you know, diarrhea is divided into three main categories. We have malabsorption diarrhea, we have secretory diarrhea. The malabsorption diarrhea is caused by defect in the liver, pancreas, congenital or acquired, or in the intestine. In the intestine, it could be a carrier defect, rush border defect, or enterocyte. Most of the congenital diarrheas are involving this side of the intestine. On the other hand, we have the secretory diarrhea. Secretory diarrhea is caused either by congenital defect in electrolyte exchange at the enterocyte level or presence of secretory agent in the circulation that will stimulate the enterocyte to secrete water and electrolytes. The third category is inflammatory diarrhea, which is usually bloody, associated with mucus, and it's the case of patient with early onset IBD associated with immune dysregulation. In our experience for the last 5 to 7 years, we have 50 cases of congenital chloride losing diarrhea, 6 cases of tufting enteropathy or congenital tufting enteropathy. We have 6 cases of tracheohepatic syndrome, 2 cases of microvillus inclusion disease, and 6 cases of immune dysregulation. Determination of the diarrhea type. We have 2 main types, osmotic and secretory. Osmotic, characterized by decreased stool volume. It's responding to fasting with low sodium concentration in the stool as compared to secretory diarrhea, and the fecal osmotic gap is usually high, more than 100 millimole per liter. So starting with some of the congenital diarrhea disorders, they are a rare inherited disorders, usually inherited as autosomal recessive pattern. They are present in the early life, early infancy, first few months of life. Some of them, though rare, they can present later on, maybe after the 9 months of life. It is due to defect in the enteroendocrine cell or dysregulation of intestinal immune response or enterocyte defect. We are seeing cases of number 2 and 3, but we never saw a case of enteroendocrine cell, and it's very rare anyway in the literature. Starting with congenital tufting enteropathy, as I mentioned, it's characterized by severe early onset diarrhea with severe metabolic acidosis and failure to thrive, although they have malabsorption, but the net result will be secretory diarrhea. Etiology, the prevalence is 1 in 50,000 to 1 in 100,000, but I'm sure that it's more common in our community because we have increased consanguineous marriage. It is either due to mutation in the EBCAM epithelial cell adhesion molecule or SPINT gene. In the EBCAM mutation, it is the more common 75% of cases, and it is presenting with isolated intestinal disease, whereas a mutation in the SPINT gene is the syndromatic form of the disease and compromises 25% of cases, usually associated with other dysmorphic and other anatomic malformation. Location for EBCAM gene in chromosome number 2, SPINT gene in chromosome number 19. As you know, the enterocytes are joined together by several junctions. The most important of which we are interested in with EBCAM presence is the claudin 7, occludin, and cadrines. The EBCAM will come and join claudin 7 and cadrine. It will strengthen this junction. So imagine if the EBCAM is not available there, this junction will be very weak and this enterocyte will be separated. So if there is no EBCAM, there is loss of tight junction. Normally, we have the enterocyte are formed of one, and they are joined by tight junction with intact microvilli. In patients with EBCAM mutation, the end result of the EBCAM deficiency or mutation is decrease Claudin 7. Decrease Claudin 7 and cadherin will lead to separation of the enterocyte, as I mentioned. Separation of the enterocyte lead to loss of contact inhibition between the cell. This will lead to increased proliferation of migration of the enterocyte into the apical area, leading to tuft formation. Due to loss of the tight junction, there will be a gap junction between the cells, and there will be a varying degree of villus atrophy. There will be increased desmosome number and length because of the rapid turnover of these enterocytes. In histology, they have villus atrophy and tufting formation, crowdedness of the enterocyte at the apical area. As compared to microvillus inclusion disease, the basement membrane for the patient with EBCAM mutation is intact. Very nice apical membrane or basement membrane here. For the EBCAM, there are certain stains which are expressed. The stain for desmoglein, which is in the basolateral membrane here, is overexpressed, indicating desmosomes. For the stain of laminin, it's very faint in cases of EBCAM mutation, whereas the heparin sulfate is overexpressed. In electron microscopy, as we see, the control, the desmosome are very few there, but here they are increased in number, and there is a presence of gap junction between the enterocyte. Another slide of electron microscopy. In special stain, other stains for EBCAM mutation, I choose the LAM stain for the desmosome and EBCAM stain. As you can see, the desmosome very well arranged at the apical area, and the EBCAM also very well arranged at the basolateral membrane. In the patient with congenital tufting enteropathy, these are displaced into the subapical area and into the cytoplasm, and they form granule-like. Outcome, most of the patients will require TBN, and some of them will require intestinal transplantation, and very few are, although minority of them, they may be weaned from the TBN. In our institution, we have 6 cases. All of them have the same mutation. Number 1 and 2 patients, they are twin sister, and they are weaned from 24-hour TBN to less than 12 hours a day of TBN. Number 4 and number 6 are completely weaned from the TBN, and they are on IV fluid only, though they are developing from time to time severe metabolic acidosis and bouts of diarrhea. Microvillus inclusion disease, again, this is a very rare disease. It is characterized by presence of early onset diarrhea with small absorption. The net result of diarrhea is usually secretory. Etiology, it is autosomal recessive. The incidence is not known, but in Novago reservation in Arizona suggests that the incidence might be high as 1 in 12,000. However, in one online registry, only 137 cases reported, and I'm sure there are a lot of cases not reported yet. It's due to mutation in myosin B or syntaxil 3, chromosome location number 18 in myosin B and 11 in syntaxil 3. Normally, what happens, the physical, which is originated from the Golgi body, will carry the proteins. These proteins are important for assembling normal villi and microvilli. So it will go there and it will lay down all of the functional protein and structural protein. Not only that, this physical should go and fuse to the apical membrane there to lay down the rest of the cargo. So any defect that prevents this physical from going up or trafficking up to the apical area, or defective fusion to the apical membrane will cause microvillus inclusion disease. So uncoupling of myosin B3. Myosin B3 will join RAB protein. This RAB protein will allow the movement of the vesicle into the apical area to lay down the protein. And if myosin 5B is absent, therefore everything carried in this vesicle will be laid down in the subapical area, and this vesicle will be transformed into a microvillus inclusion, which is almost pathognomic for microvillus inclusion disease. The other defect is fusion defect between the physical and the apical membrane. This is mediated through the junction between syntaxin 3 protein and V-snare protein. So when they are joined together, it will build this physical also to lay down the cargo protein needed for function as well as structure of the apical epithelium. So defect in that will cause atypical form of the microvillus inclusion disease. In histopathology, with periodic acid shift, there is accumulation of positive pass material in the cytoplasm. In the CD10 stain, there is a thickened subapical membrane as compared to the normal here. In special stain for congenital villus atrophy, stain for villine, which represent actin molecules, and syntaxin. These are normally positioned here. With the defect, there is distortion of the membrane, and you can see also this membrane is encircling the microvillus there. The same thing is applied for the syntaxin stain. In electron microscopy, there is, as I mentioned, trafficking defect. This physical will go and form microvillus inclusion as seen here in the electron microscopy. Outcome, most of the patients of congenital villus atrophy or microvillus inclusion disease, they have poor prognosis. They either die from the complication of TBN, like sepsis or liver disease, or after transplantation, most of them will develop complications. A minority of them, they may develop autonomy of their intestine, and they can be weaned from the TBN to once or twice per week. We had 2 cases diagnosed by intestinal biopsy and electron microscopy. One case died because of the long-term complication of TBN. This patient remained with us for about 2.5 to 3 years. And the other case was transplanted in US, and she died shortly after transplant. The other syndrome is tracheohepatic enteric syndrome, characterized by chronic diarrhea, malabsorption, and they have other dysmorphic feature, and they are prone to have immune deficiency, and they can develop early onset IBD. This is their dysmorphism. They have the breast nasal bridge. They have hypertelorism with the frontal posing and typical hair or woolly hair. It is associated with mutation in TTC37 tetratricopeptide repeat protein or SCY-V2L mutation. It's very rare though, it's 1 in 1 million. The location of TTC37 mutation is in chromosome number 5 and SCY-V2L in chromosome number 6. The defect is in the nuclear protein, TTC37. It is a transport protein, and this protein also allows the protein-to-protein interaction and transport. So the transport of certain protein to the apical area will be affected. Management and treatment, patient will require long-term TBN. They are prone to have recurrent infection because of the variable degree of hypogammaglobulinemia. Therefore, they need immunoglobulin from time to time. Prognosis is poor with mortality rate of more than 50%. We have 6 cases of tracheohepatic enteric syndrome. 5 of them, they have SCY-V2L mutation, and 1 case TTC37. All of these cases have hypogammaglobulinemia, and they are receiving IVIG. And most of them, they develop or have skin lesion in form of caffeole spots. Probably the last disease will be Ibex syndrome or Ibex-like syndrome. It is causing or a form of immune dysregulation. It causes severe diarrhea, failure to thrive, dermatitis, and autoimmune diseases in form of type 1 diabetes mellitus and other autoimmune disease like thyroid disease. They may have autoimmune thrombocytopenia and anemia. And Ibex syndrome can involve the liver and the kidneys. Etiology affect estimated 1.6 million people. It is due to mutation in the FOXP3 gene or CTLA4, which impair the normal function of T cell. The T cell is responsible for self-tolerance, preventing the body from eating itself. So any problems with the T regulatory cell or Treg cell would lead to autoimmunity. The FOXP3 is B3 gene is inherited as X-linked recessive, and the CTLA4 is inherited as autosomal dominant. As I mentioned, the Treg cell will neutralize the activated effector cell. When they finish doing their job from neutralizing the invading antigen, they should be stopped. Otherwise, when they are exaggerated, they will lead to self-damage. So this function is mediated through the FOXP3. FOXP3 will increase CTLA4, CD25, and decrease the interleukin-2, which is responsible for T cell recruitment. So the TCL4 will be responsible for suppressing the fusion between the T cell and antigen-presenting cell. It will lead to a net negative signal. So when the junction between the lymphocyte and antigen-presenting cell is accomplished, a certain reaction will occur and the antigen will be damaged. But if this process is exaggerated, there will be overexpression of CTLA4 and then suppression of these T cells. Patients with CTLA4 deficiency are usually treated with abatacept, which is immunoglobulins resembling in its action CTLA4. FOXP3 in chromosome number X, CTLA4 in chromosome number 2. Diagnosis clinical and biochemical, flow cytometry, peripheral blood, CD4, CD25, and FOXP3. Usually feed decreased in T cell in patients with Ibex syndrome. And the golden standard is gene study. We have to treat the complication, and the treatment of Ibex is bone marrow transplantation, but treatment of Ibex-like syndrome due to TCLA4 is abatacept, which is a good indication. So we had 2 cases of FOXP3 mutation. One developed only diarrhea, and the other one developed full-blown picture with autoimmunity skin lesion. One of them is going to the bone marrow transplantation now, recently. And the other 2 cases, CTLA4 mutation, they developed severe diarrhea, cachexia, failure to thrive in the first few months of life. They required TBN for a long period of time, and when we got the result of whole genome sequencing, we get CTLA4. These patients were started on abatacept, and they have complete resolution of diarrhea, and they are weaned completely from the TBN. Do I have time, or? The last probably slide will be very early onset inflammatory bowel disease. It's a very rare and represent 1% of all IBD. In pediatric or infancy, it's usually restricted to the colon rather than to the small intestine, resistant to many of the standard medication for IBD like immune suppression. They can present with the perianal fistulas and often have much stronger family history, and can be caused by mutation interleukin-10 or its receptor. Now, we had 2 sisters, all of them diagnosed in the early infancy. All of them developed perianal fistula and bloody diarrhea. We did scopes for them. Our diagnosis was IBD because they have ulcerative colitis-like picture in their histopathology. However, phenotypic manifestation of Crohn's disease, they have perianal fistulas. These patients were started on immune suppression medication. The elder sister did well after starting the immune suppression, but we realized that frequently she is visiting the hospital because of the frequent relapse and infected perianal fistulas. The other sister was diagnosed at 2 months of age, and she had a scope, and after that we started immunosuppression, and she died after that with sepsis. The elder sister went abroad with the report, and she had a diagnosis of possible interleukin 10 deficiency or receptor defect. This patient got bone marrow transplantation, and unfortunately she died after that. For those who attended, Professor Olivier, who is from France, he is distinguished Spigan speaker, he presented 4 cases with immune dysregulation and IBD-like picture, and he gave the same experience of early death because of this disease, and they are not responding to the immune suppressive medication. So he realized that this patient may get benefit from bone marrow transplantation. One of the siblings, okay, I'm finishing. One of the siblings who died, he has another sibling who is newly delivered, and they decided to do bone marrow transplant for him. When they did bone marrow transplant, the patient did very well, and he is still alive till now. So patient with early onset IBD, consider interleukin 10 deficiency or receptor defect, and this patient, probably with other immune dysregulation, they have difficulty in responding to immune suppressive medication, and this patient will get benefit from bone marrow transplantation. I think I have to conclude here. Thank you very much.